Thank you, Matt, and thank you, Kathy. First, before I start, I just want to thank the Center for the invitation to participate in the webinar. Transition issues are just really so important, and it's a real pleasure to join Kathy in tackling the topic. As Matt noted, I am an attorney with Justice in Aging. If you don't know us, we've been fighting senior poverty for 44 years, focusing on access to health care and economic security. We used to be called the National Senior Citizens Law Center, but about 1.5 years ago we changed our name to Justice in Aging. Much of what we do seeks to improve programs that can impact the lives of older adults who qualify for both Medicare and Medicaid. And those are the same programs used by individuals under 65 with disabilities. So our work overlaps very much with the topic today, and our advocacy work very much relates to the great work that the Center for Medicare Advocacy is doing on this project. And we do also closely collaborate with the disability advocacy community so that our joint voices can have a maximum impact. Today I'm going to talk about transitions for people with disabilities who already have Medicaid coverage and then qualify for Medicare. So when does this happen? What is the typical scenario? How does it change things for the individual? What is different? What's easier? What gets harder? And finally, what is some basic guidance that advocates can give consumers so they'll know what to expect? How can you make the transition a little easier for your clients? Unlike the complexities of enrollment that Kathy has been talking about, and it's stunning, the complexities, enrollment in Medicare for people who are already on Medicaid, usually it's just automatic. Low-income people with Medicaid coverage that was based on a finding of disability may well have had Medicaid for 2 years or more while waiting for Medicare coverage. Medicaid was covering their hospital claims, their drugs, their doctor, other providers, their medical equipment, supplies, personal care services, and other long-term services and supports that they may have been using. Then they become eligible for Medicare 24 months after the date of their eligibility for SSDI, for Social Security Disability Insurance, which, as Kathy noted, really is 29 months after they actually had the onset of their disability. But with Medicaid, you can apply right at the onset and in many cases get a determination that was effective the month of the application. So this could mean that many people are receiving disability Medicaid benefits for more than 2 years before their Medicare kicks in. And when they reach that moment, when they become eligible for Medicare, the state Medicaid agency will automatically start paying their Part B premiums and, if needed, their Part A premiums. So it's all automatic. And as we'll see in a minute, it means a significant switchover in how people get their services. Now, there could be variations here, and sometimes the period when someone with a disability is on Medicaid alone can be significantly shorter. As Kathy told you, people with ALS, with Lou Gehrig's disease, qualify for Medicare the month that their disability benefits begin. And for people with ESRD, coverage also starts earlier than the 24 months of the disability. So in these cases, individuals who qualify for Medicaid coverage may have been on Medicaid for a much shorter period, or they might even qualify for Medicare and Medicaid almost simultaneously. Some people also may have been on Expansion Medicaid before the onset of their disability. For example, let's just take someone, let's call her Mary. She's very low income. She lives in California, and California is a state that offers Medicaid coverage to adults under 65. So she's been on Expansion Medicaid for 2 years. Then she gets diagnosed with ALS and she becomes disabled. She starts Medicare coverage right away and also qualifies for Medicaid coverage based on her disability. So her Medicaid coverage will switch from Expansion Medicaid to disability-based Medicaid, and she'll also qualify for Medicare, and all this will happen pretty much at the same time. So I just wanted to point out that there's a number of different scenarios here. And just to be comprehensive, there also will be people under 65 who have disabilities but chose to belong to Expansion Medicaid rather than qualifying for disability-based Medicaid. Depending on how the benefit packages are designed in particular states, that route might have been chosen because it offered somewhat better benefits. Or it might have just been easier than going through the whole steps of proving a disability. In those cases, when they turn 65 and qualify for Medicare, they can no longer use Expansion Medicaid, and they'll have to get their Medicaid based on their disability. And others might have been in Expansion Medicaid and qualified under the income and asset limits for Expansion Medicaid. When they turn 65, they find they can't qualify for disability Medicaid, perhaps because their assets are too high, or maybe their income is above the state's cutoff for disability Medicaid. So in those cases, despite their disability, they might only get Medicare on turning 65 and lose their Medicaid coverage. In those cases, too, you want to be very careful to make sure that they've been screened for any Medicare savings program that would help reduce their Medicare cost, and for the low-income subsidy for Medicare Part D. And then finally, there are those less common transitions at the end when people lose Medicare after being determined to no longer be disabled. And Kathy's going to talk about these in a few minutes. But I just want to point out that with Medicaid, like Medicare, there are some opportunities to stay on the program for some time after the end of the disability, depending on your situation. Getting back to the way things usually happen, let's look at a typical case. A person who's been getting Medicaid coverage for a couple of years, and then one day, 29 months after first applying for after the onset of the disability, is eligible for Medicare. What's the practical impact for the person with the disability? Well, first, the good news, which we already talked about, the change is automatic. There should be, if everything goes well, no gap in coverage. The individual doesn't have to do anything to make it happen. But then what is it that is happening? What really are the changes? One area of significant change is prescription drug coverage. The day Medicare starts, the individual must get all their prescription drugs through Medicare. The only drugs that they can continue to get through Medicaid are drugs that Medicare never covers, like over-the-counter drugs. So how does this play out? Individuals will have been auto-enrolled into a Medicare Part D plan. That plan will have prior authorization requirements. It won't cover every drug. It will have a limited network of pharmacies. And all of this can be a big change for someone who has been on Medicaid. In many states, Medicaid formularies are open, covering every drug. When states have restrictions on their formulary, they often are fewer than those imposed by Medicare Part D plans. And the limits on pharmacies might be new. In some states, all or almost all pharmacies take Medicaid, so someone with Medicaid doesn't have to think about in-network or out-of-network pharmacies. And there's copays. Most Medicaid programs charge nothing for prescriptions. And if you have 10 or 12 prescriptions that you're filling, and now you're on Medicare Part D and you're paying $6, or even if it's just $2 a piece, that's a lot out of a budget where every penny counts. So that's all new for someone with Medicaid. And auto-enrollment, as I'm sure SHIP counselors out there know for sure, doesn't necessarily mean that the individual is in the best Part D plan for his needs. Getting the most out of Medicare really requires more active involvement. picking a plan that is best suited to your prescription drug needs. Perhaps also needing more to engage your prescriber in supporting exceptions that might not have been needed under Medicaid. Medicare just requires more active work to work well. But there is Medicare's transition policy, which allows one fill of existing medications even if they are not on the plan's formulary, and that gives people a little bit of breathing room. There's an excellent prior webinar on Part D issues that was part of this series, and it's also available on the Medicare Advocacy website. So I'd recommend, if you haven't been part of that webinar, to look at that to get into this a little bit more in depth. We hear from consumers with disabilities that transitioning is particularly challenging with durable medical equipment and supplies, known as DME. Many beneficiaries with disabilities have really significant DME needs, and this can be hugely important in their day-to-day living. The challenge is that some DME is covered by Medicare and some by Medicaid. So, issue one, Medicare-approved suppliers and Medicaid-approved suppliers are not always the same companies. This situation has gotten considerably more problematic as Medicare has expanded its competitive bidding initiative. To save money and combat fraud, CMS has significantly limited the number of suppliers you can use for certain Medicare-covered DME. Now, this has changed things for everybody on Medicare, but the narrowing of choice is particularly challenging for people who are moving from Medicaid alone and were set up with one set of suppliers, and now they need to make adjustments and they may have to switch some of their suppliers to someone else. Another issue that arises from the overlap of Medicare and Medicaid coverage. Medicaid is always the payer of last resort, which means that Medicaid can't pay for something until the bill has run through any other insurance that you have. And now that a person with disabilities has Medicare, that means that many charges have to run through Medicare first before the Medicaid agency will consider paying. So that makes things complicated. The real complication can be that Medicare won't review a claim until after the item has been delivered. Medicaid programs generally will give you a prior authorization before delivery. Now, some states insist on waiting until there's a rejection from Medicare before they'll even process a prior authorization. So you get into this catch-22 where you've got a supplier. The supplier doesn't want to deliver the equipment until he knows that somebody's going to pay for it, either Medicare or Medicaid. But the whole process doesn't start until the equipment's delivered. So if it happens that way, you can really get stuck, and it usually takes some advocacy intervention to untangle things. We and other advocates are working with CMS to advocate for a universal fix, and the Center for Medicare Advocacy has been very instrumental in this process. But in the meantime, new duals can run into this disruption in access to supplies that they were getting routinely through Medicaid, and suddenly there's this glitch that can really be significant if you need the equipment. There's going to be a webinar in this series on the details of DME, and I highly recommend taking some time to dig deeper into this topic as well. With doctors and hospitals, starting Medicare coverage can really be an important plus, a real positive, giving access to Medicare providers, including those who don't take Medicaid. And most duals are protected from any billing by their Medicare provider for coinsurance or deductibles. And that protection is what we call balanced billing protection. I expect many of you have heard us and others provide training on that. Most people with disabilities who become full dual eligibles do have these protections. Any dual with income below 100% of poverty, is a qualified Medicare beneficiary, a QIMBY. And because they have full scope Medicaid, we sometimes call them a QIMBY Plus, which is they've got both Medicaid and QIMBY. And anybody who's a QIMBY Plus gets this protection. Also, anybody who's just a QIMBY gets it as well. Also, any full dual, even if they're not a QIMBY, gets the protection from copays if they're in a Medicare Advantage plan. We have a lot more on balanced billing on our website at justiceandaging.org, but it's an important protection as people move into Medicare. And when talking about Medicare hospital and Medicare provider benefits, it's important to remember that most people who are Medicaid first and then get Medicare coverage, they're going to be defaulted into fee-for-service original Medicare with an auto-enrollment into a Part D plan. But some of them who are in a Medicaid managed care plan, and more states are moving Medicaid enrollees into managed care, some of them might be enrolled directly into a D-SNP that is run by the same plan sponsor that runs their Medicaid plan. They call this seamless enrollment. There's not a lot of that out there, but you may run into it and see some clients who've had that happen. And some who are in states where there's a dual eligible demonstration project might get passively enrolled into a combined plan that covers both their Medicare and their Medicaid benefits. Now, in both cases, people have the right to change and to move out into fee-for-service Medicare. But in some cases, actually being in a coordinated D-SNP or a Medicare Medicaid plan may be a good option for someone depending on their circumstances and their need for care coordination. But what I wanted to point out is that people might be caught unawares of the fact that this had happened, either because they didn't read their mail or they may be confused by the mail that they do read. So this is just one more instance where, because you have Medicare added to your Medicaid, you just need to have more active involvement in managing your benefit. And as states are adopting the managed care model for their Medicaid beneficiaries, it's important to keep in mind some special issues that for these individuals as they move into Medicare. Many Medicaid for Medicare services, once you've become a dual eligible, you don't need to use providers who are part of your Medicaid plans network. You can use any Medicare provider. You don't need any prior authorization from your Medicaid plan for Medicare services, but you do have to follow the Medicaid plans rules for Medicaid services. And some more general changes for someone moving from straight Medicaid. There's 2 appeal systems depending on the service. If you get a denial of a Medicare covered service, you have to go up the Medicare route. If you get a denial from the Medicaid service, you have to go up the Medicaid route. Medicare, quite frankly, is not as good as some states on language access. In California, where I live, for example, a lot of Medicaid notices are routinely translated into 13 languages. But in Medicare, with only a few exceptions, Spanish is pretty much it. Limited English proficient beneficiaries are likely going to need to rely more on oral interpretation, and that is available in both systems to understand communications, and they need to be encouraged to aggressively ask for interpreters. Hopefully this will change over time, but that's where things are right now. And finally, there's the onslaught of mail, marketing mail, mail from your Part D plan, mail from Medicare, attempts from brokers to try to get you to join a plan, and the marketing goes on all year. This is a big change from Medicaid, where there's far fewer choices, sometimes none, and the result is there's far less mail. So as advocates, you may encounter someone with a disability who's about to start Medicare and wants to talk about Part D plan choices, or maybe they just ran into an access problem with drugs or DME. And whatever the original reason for the contact. It's an opportunity to run through these issues that we've just talked about and to better prepare and empower the individual for what these changes are. Just having a very, very basic understanding of what changes to expect and knowing that there's help out there can make all the difference. And we just have a couple of other specific suggestions. This is really important. We've seen this several times. You get a consumer who says, this is all too complicated. I liked things the way they were. I had everything lined up. I was getting my supplies. I was getting my drugs. Everything works. Now it doesn't. It's all confusing. I don't need Medicare. I don't want it. I just want to go back to Medicaid. If you have a client saying that, you need to be really specific. This is black and white, and it's super important. Dropping Medicare is not an option. The state Medicaid program can enroll an individual in Part B without the individual's consent. If you continue to refuse Medicare coverage, your state will treat this as a request to disenroll from Medicaid. The state will not allow you to stay in Medicaid if you disenroll from Medicare. So if you try to disenroll from Medicare, you'll have no coverage. You won't have Medicaid, and you won't have Medicare Part B. So if someone comes to you and they say they've already called up the Social Security Administration and disenrolled from Medicare, tell them to call back and tell Social Security they made a mistake. If they run into a problem, get them to legal services to work to get this undone, because it can really be a very, very, very bad move. And some other basic messages. Consumers have 2 cards now. They should show them both all the time. That's important so that Medicare providers are on notice that they can't be balance billed. Being in both programs is more work. Medicare is market-based, much more so than Medicaid. There's more choices, but that means more need to be informed and to really sit down and make those choices. It also means there's more bombardment year-round with marketing, but it's important to open your mail, stay on top of the real messages from CMS and from Medicaid and from the Part D plan. People need to know their rights, be particularly around balance billing, and speak up when they think that they are being billed incorrectly, that when things get complicated, SHIPs are available, legal services are available, disability rights advocacy organizations are available, that there's help out there. And the final message is that over time it gets easier, it does settle down, and if you run into a jam, help is out there. So we've covered a lot. My point is not to make you an expert in all of this, but to spot issues for you and give you a flavor of the many ways that things change all at once for someone who has a disability and is moving from Medicaid to Medicare, so that you can better be able to provide support and assistance.